Hello, and thank you for joining us. My name is Cassidy Avila with the Center for Optimizing Rural Health at Texas A&M University. Welcome to the webinar on coding and billing in rural health. Our speaker today is Patty Hildebrand. She has provided us with several handouts to share with you, so watch for those in your inbox after the webinar. You'll also receive a link to a very quick survey. It takes less than a minute, so we would appreciate your feedback, and we welcome you to suggest a topic that you might like to see offered in webinar format in the future. So right now, you're set to mute, but we will be taking questions at the end of Ms. Hildebrand's presentation. So let me begin by introducing Patty Hildebrand. Ms. Hildebrand is a seasoned healthcare professional with over 40 years of experience in direct care, administration, and consulting, including over a decade consulting with healthcare organizations to help them meet regulatory compliance and accreditation readiness requirements. In addition to her previous experience as a nurse practitioner, she's a certified rural healthcare professional, a certified coder, a fellow of the American College of Healthcare Executives, a certified professional in healthcare quality and healthcare risk management. She's a certified Joint Commission professional, a black belt in Lean Six Sigma, and has been a Baldrige examiner both nationally and for the state of Texas. She is the executive director of Hildebrand Healthcare Consulting, which specializes in regulatory rescue and survey survival. So welcome, Ms. Hildebrand. Thank you for being with us. And now I'll pass the presentation over to you.
Excellent. Thank you, Cassidy. It's always kind of fun to listen to someone recite the credentials because my mother once told me that I wanted more initials after my name than I had letters in my name. And I think I succeeded. So, all right. Yeah. All right. Now, to share my slides, you can't see them now, correct? I have to.
That is correct.
All right. So, are you seeing them now?
I think they're coming up. Yes, we see them now.
Excellent. All right, let me get into presenter's view here. All right, so this is our topic today. Our presentation today is on the basics of billing and coding. One of the reasons that we decided to present on this is that whether because of the demographics and all the baby boomers are retiring and new people are coming in, whatever this reason is, that Medicare is seeing concerns or questions with the billing that are at the very basic level, not really highly nuanced, advanced type of things, but just the basics that everyone should know. And they're starting to see trends in all of these and therefore are starting to reject claims. So let's go back to basics. Let's learn some of the basic things. This will not turn you into an expert. These are merely the issues that Medicare actually has flagged as being very common. There's lots more to know, lots more to learn about coding in rural healthcare, billing and coding in rural healthcare. It's one of the more complex ones, but we'll start out with this. All right, so we have a statement we have to add in for HRSA. Their content is of the author, not of HRSA, doesn't represent their official views. So we're going to talk about several topics, some groupings of topics. Facility billing in hospitals, in particular, talking about inpatient versus outpatient versus swing. Facility billing for rural health. The hot button topic of medical necessity, because you will hear that over and over again. And then finally on E&M. And again, you're not going to be an expert on all of these. These are just the hot buttons or the hot issues that the Medicare is seeing. So on the hospital side, on the facility side, and let me back up. You're going to have more slides here and more handouts that you're going to need for the presentation. I do consulting, not education, so I give you more than you need so you can go back later to it. So some slides we're going to slide over real fast, some we're going to spend time on. So in a hospital, at the hospital, not the rural health center level, not the outpatient center, a couple things that Medicare is seeing, particularly for inpatient versus outpatient. On the inpatient side, if you are a critical access hospital, be aware that there is a 4-day standard.
Join WebEx
I think
meeting.
somebody is, could somebody mute their phone, please? We're getting some feedback here. Thank you. On the inpatient side, if you're also a critical access hospital, be aware that they have what they're calling the 4-day standard. That means in their strategic planning, they think that a critical access hospital should have a patient really no more than 4 days, in which case you're going to transfer them up to the big city, or you're going to discharge them into some sort of post-admitted type of care. Now, that doesn't mean you can't keep them longer than 4 days. It just means that their payment methodology is set up around 4 days. And that doesn't mean you have to discharge them at 4 days. You can keep them if you wish. You don't have to keep them all 4 days. You don't have to discharge them at 4 days. Just be aware that the payment scheme is set up around that 4-day payment type of average. In fact, a lot of places will have a good, strong utilization management type of aspect, and they start looking at this patient on day 1, day 2, and day 3. Are we going to keep them the full 4 days, or do we need to keep them longer, or do we need to transfer them? The concept of medical necessity, you will see that across the board, inpatient, outpatient, swing, you'll see that rural health, everything. And I will go over this in a little more detail later, but I will tell you that medical necessity is from the payer's standpoint, meaning will that payer see it as medically necessary to take funds out of the payer's funds, out of the payer's funding and accounts. This is not the same as clinical medical necessity, and it is what gets everyone in an uproar because a provider, a physician, nurse practitioner, PA, may want to admit that patient and say it's clinically appropriate to admit that patient, and it may be, but it may not be within the realm, the protocol that the payer, the insurance payer, says is medically necessary to admit them. And that's where people get into discussions, and we'll talk a bit about that later. And remember that their diagnosis is the documentation is king. If it isn't documented, it wasn't done. Now they're starting to look for very specific kinds of things. And if you look at the bullet points on that slide, the last bullet point is the one that seems to get people in trouble. And I have to admit, when I was practicing as a nurse practitioner, I hardly ever documented this last point, which was the potential risks of not admitting them. What happens if I don't admit this patient? What are the risks? And what the payers are wanting to hear, what the Medicare is wanting to hear, is that the risk of admitting them is far less than the risk of not admitting them. Now, how and why you document that is within your own organization. But most of the time, it's the clinician that ends up doing it in some way because they're the ones who can tell you clinically if it's going to make a difference. All right, so for outpatient, on the outpatient side, that was inpatient, now it's outpatient on the rural health center side. A couple things that are the hot buttons. In rural health care, a rural health care center, rural health center is a Medicare definition. Medicare decides what that is and what you must have to be considered a rural health care. They define the payment rules. Then they work with the states, and the states can define some additional rules if they wish. There are some states that make it stricter. But it's essentially a Medicare definition, which means it can be changed. Those are elected officials who control in some manner the HHS, which controls CMS. So there's a lot of influence you can have. So get to know your legislators. Medicare does define what an allowable rural health care visit is. And in your references in the slides, in the last couple of slides, you can click on various sources and find that allowable list. That is a moving target. It changes. And the list, they will say at the very beginning, it's not an all-inclusive list. So you get to play with it a bit. And remember that your cost report, this is that huge report you have to fill at the end of the year. You have until May to fill it. List what it cost you to deliver the care that you said you delivered, right? This is not what you got reimbursed. This is what it cost you, and the difference between what it cost you and, of course, what you got reimbursed. There, you often get a portion of that, and sometimes all of it, back from the state. As far as we talked inpatient, outpatient, now we're talking about swing. In swing, the issue seems to be geography. Remember that swing bed is a billing status. It is not a geographical location. In fact, you can have a patient in a bed, and let's just arbitrarily call the room 2A East, all right? That patient could be in 2A East on Monday as an inpatient, and then at some point during the day when the clinicians decide that that patient no longer meets medical necessity for inpatient care, but now needs a lower acuity care, they can now classify that same patient in that same bed, in that same room as a swing bed. Now, what does that mean to you on the billing side? Well, it means a lot because you have to know when you fill out the bill, there is a location of service code on that UB04, and you have to make sure you use the right location of service code. One of the handouts you either have or you'll get is one I found a while ago that it's a little bit older, but it is still a nice brief description of how to fill out that UB04. It's really nice for somebody that's new, has never filled one out. I've also used it kind of as an eye-opener when I'm training clinicians to say, this is the information your billers have to have before they can drop the bill. Are you providing all that information? Because frankly, most of the time it's coming from the clinicians. The one that gets a facility all the time is when they do go to swing bed and they do change that location of service, they have to be legally discharged from inpatient care and then admitted to swing bed. Now, that can be as simple as a progress note, right? But most places will have a different chart or a different portion of the electronic medical record to document progress notes for acute inpatient care versus swing care. And the reason for this is swing care is considered a less acute care, and therefore the rules about how often they have to be checked, how often they have to be seen, how often you have to take vital signs on them, those are all lesser for swing bed. Just imagine what would happen if you did not put that in your clinical documentation and an attorney got a hold of your documentation to say, well, how come you didn't see Mrs. Jones every 4 hours? Well, it's because she's now swing bed. Well, how do you know? That wasn't documented. And remember, too, that there's some unique needs as far as what coding systems you use. And this should be old hat to you, but I'm putting it in here just for completeness. Sake, that if you happen to be in an organization that bills for both the facility and for the providers, the physicians, nurses, and PAs, remember you're using two different systems. Everybody has to use the ICD-10-CM for diagnosis now. No one gets out of that except if you're in behavioral health, you sometimes get to use what's called the DSM. But whether you use an ICD-10 PCS for procedures or whether you use a CPT depends on who's billing. That means if you're a biller that does both, that means you're going to have to do different forms. I do have a nice chart later on from National Association of Rural Healthcare Centers that lists it out very nice, and I've actually printed that out and given it to billers just so they can have a cheat sheet. This is the other one that gets very hard for clinicians to understand because in their mind, if the patient has, I'm going to say Medicare as an example, and Medicare says it covers service XYZ, and the physician provides the service XYZ, they ought to be able to get reimbursement for it, but it isn't always so. What I will tell you is that go check your claims processing manual. Down at the bottom of the slide, you can see where you need to, what chapter you need to look, and at the end of the presentation, I have a link to the actual chapter so you can look at. I would download that and just kind of have it because a lot of times I have had clients who've been able to successfully challenge a denial because they were able to quote right from the manual and say, this is supposedly covered. It says it's covered if I do XYZ, I did XYZ, therefore I should get paid. Don't be afraid to use their own manuals against them. A lot of what I do whenever I go somewhere that's having issues with their revenue stream is because it's really hard to say that everyone's performing at 100% every day. I have bad days. Everyone has bad days. There's days I forget stuff. I like the checklist method. Airline industry uses it. I see nothing wrong with having a bunch of checklists. The things you want to do on checklists for before you drop the bill, before you send off the bill, are on this slide. One of the newest ones is that one's in blue. And that's where you have to add, and you must, it's a requirement, to add the CG modifier on the line on your UB04 that totals all the bundled charges. You're going to bundle all your charges for that day. Even though you may list everything on multiple lines, you're going to bundle all charges under one of the lines and add the CG modifier to that line, right? No, that's not what you're going to get paid. You're still going to get your AIR on that, but you're watching that because at the end of the year, all this, your cost report's going to be able to reflect the total amount. I kind of use it as a last-minute checklist. Whoever is that person that's responsible for dropping the deal, just make sure they've got these things on their little checklist. Remember, too, that each line must have a revenue code. That's a relatively new standard. Your revenue codes are going to typically be 052 something, 052, some additional, or 0900. Print up all the revenue codes for your facility. Now, realize your facility may not do every single thing that it has a revenue code. Your facility may be individual, so just print up the ones you need. In rural healthcare centers, there is this concept of qualifying visits. Qualifying visits, to be a qualified visit, you must have a medically necessary, there's that concept, medical necessary face-to-face with the provider. And I'm looking at a typo right now. I apologize for that. Now, remember, your providers are listed out as to who they can be, right? So, and your particular rural health center will list which providers they have. Now, the fun part comes in is I actually had a client who got caught on this. They opened up at a much lesser scope because they just wanted to get open, and then they were lucky. They grew over time. They added a dentist. They added this, that, and everything, and they never changed their scope. The actual document that is within their bylaws that says this is what we'll offer. Well, then they went to bill something, and for whatever reason, they got audited. And the auditor actually did the remote audit where they asked for records and then came on site. They really didn't like what they saw. When they came on site, one of the first things they asked for was the organization's bylaws and scope. And since the scope said they didn't include dental services and yet they were billing for dental services, they got denied. That bill got denied because they were offering something not within their published scope. So just be aware that this is a document that probably needs reviewed at least once a year. CMS also there's that link for that qualifying visit list. And again, it's not all inclusive. There's more that could be. Remember, you've got two different sets of fees. We talked about some are the facility, some are the actual physician. And we're going to talk about, physician, nurse practitioner, or PA. We'll talk about E&M toward the end. There are some changes with E&M that are good and some that are bad. This is the nice chart that I thought that NARHC published. If any of you are members or you listen in to their technical assistance calls, I think they offer a wealth of information. Even simple little cheat sheets like this can go a long way just to helping consistency in performance by your staff. Because remember, you have turnover and people have bad days, and sometimes it's confusing when you have a bill that has a mix of things. Maybe it's not all professional services in the rural healthcare. Ancillaries always are confused, or a source of confusion. The trick to remember is that you have to split out on the imaging and EKG, you have to split out the technical component and the professional component. The technical component, for those of you who don't do coding, is just the actual act of performing the test. And the professional component is the interpretation of the test. You can do all the x-rays in the world, but a radiologist has to look at the results, right? And you have to code them separately. Because they go on different bills. The professional component goes on one side and the facility charge goes on another. On the labs, all of the labs none of the labs rather can go on the performance of the lab test cannot go on the rural healthcare facility bill. It has to go on the professional bill. And of course, there's the 6 lab services you must provide to be called a rural health. The thing that gets confusing is if you're drawing the blood or you're getting a culture ready, let's use that one. You're getting a culture ready, you get the sample ready in the tube and you're packaging and you're sending it off. You don't get to bill for performing the test. The lab that actually does the test, does the culturing, gets to bill for the test. And that can be a bit of confusion sometimes. So that was facility billing both for the hospital side and the rural health. Under medical necessity, these are really hot buttons, and I'm telling you, this is the usual scheme is you get denied and you don't know why, and when you call up to get the denial code or you contact contacted the insurer, and they'll say it's medical necessity. Well, with medical necessity, either your diagnosis is clearly indicative of the medical necessity. The example I give is somebody being admitted for a cholecystectomy, having their gallbladder out, and their diagnosis is cholecystitis or cholelithiasis, right? Clearly indicative of the medical need to have it out, right? But let's say, the one that comes to mind is pneumonia. What if they have a diagnosis of pneumonia? It's not immediately obvious that they need admitted, okay? It is immediately obvious that they need treatment of some sort, but not necessarily inpatient. So it's very easy for an insurer to deny based on lack of medical necessity. So this is where your clinical documentation comes into play. Now, the unfortunate part about this is if they're denying the bill on the front end, right, and they're saying we're not going to pay, there's no obvious medical necessity. Now you have to get copies of medical records. Now you have to rebill. And it's basically what those of us who do Lean Six Sigma, we call this rework. You're having to churn around and around and around to go get what you need. It's the most effective business practices to send them everything they need first. So if the diagnosis that is given by the provider is not clearly indicative of medical necessity, maybe before you drop that bill, go talk to that provider and see if there isn't any kind of addendums they can do to the clinical documentation. Remember that medical necessity is from the provider's point of view, from the payer's point of view, not the provider's point of view. The payers, these insurers, have a contract, so to speak, with their customers that they will pay under certain conditions. Well, their customer isn't necessarily the provider. Their customer is that patient who is paying premiums, or sometimes it's an employer paying premium. So they have basically a fiscal duty to conserve as much money as they can to pay for the things they promise to pay. So anything that's in question, it is their fiscal duty to stop and say, wait, give me more proof. Now, having been on both sides of this equation, I can tell you it doesn't feel like that when they don't pay, but this is how it works out financially. From a clinical standpoint, from a clinician standpoint, look at that second bullet. Every test that is ordered needs to have what in clinical terms is called an indication. In other words, the reason why that particular test being done. Now, it becomes very hard from a clinician standpoint, and I'm guilty of this myself. Sometimes it's painfully obvious to me why I would need that test. Why should I have to say that I want a chest x-ray to rule out bilateral pneumonia, right? If I don't say that, no one can code it, no one can do anything for that until I actually put it in clinical documentation. Because remember, a coder, a case manager, no one can assume it has to be based on the clinician's documentation. So sometimes I know some facilities will kind of force the system to force the providers to provide an indication for every test by filling out a requisition slip, and on the requisition slip it says, what is your test, or what is your indication, or what is your diagnosis? And of course, you all know that the providers don't fill out those requisition slips. It's some poor person sitting at the desk. So be aware that this should be in your clinical documentation, and it's a really good one to train your providers to do. I used to have contests where I handed out candy bars to people that had the best documentation. Funniest thing, they would fight over Snickers bars. I don't know why, but they did. All right, again, it's from a payer point of view. Remember that the person looking at this would consider it not necessary if it's not obvious. And the person reviewing the chart isn't always a medical professional. Let me just warn you, a lot of times they're accounting professionals. In fact, there's quite a few insurers have hired former IRS auditors without clinical background. So the words have to be words they recognize. They have to be very commonly used words. They have to be very clearly linked and aligned to what you're trying to do. The other thing is they have, for quite a few years now, refused admissions for diagnostic testing if that diagnostic testing is available outpatient. Some aren't, but most are. So they'll say, why do you need to admit? It has to be very clear in your documentation what this patient's condition is and why they require inpatient admission while you're going through the rest of your diagnostics. There is a Medicare inpatient-only procedure list, which I think you should all know about, and there's the link for it on this slide. So the next hot button is that whole concept of whether it's an inpatient, outpatient, or rural health. There on your first button, there are the providers that a rural health care center through Medicare will recognize as a provider that would do a medically necessary face-to-face visit with the rural health care center. I'm looking for the one, I don't see it on the slide. Be aware that they are watching now. A lot of times your front office people and your back office people like to be very efficient, and they like to put patients back in rooms before the provider actually gets there, so that when the provider gets there, they can, drop their wallet on the desk and start seeing patients. Unfortunately, that provider, one of those in the first bullet, have to be under the roof, in the house, before you can take a patient back to the room. It's actually due to the safety considerations. Once you take them back to the room, you are expected to respond to any clinical emergencies that patient has. Therefore, you can't respond to that clinical emergency unless one of those providers is under the roof. As of 1119, bullet number 4, the encounter can also be a virtual communication. We're going to go over that because that's so hot now. I think that is going to be a source for their constant audit and constant review. Remember the 30-day visit under bullet 6, the 30-day margin bracket. 30 days before, 30 days after a provider visit, you can have a non-provider visit. A couple key ideas with a rural health care billing. No advanced rooming of patient, which we talked about. And remember, it had to be those 6 or so approved providers before you could take them back. And again, think of why. This is not meant as an insult to a podiatrist or a chiropractor. I have colleagues who I think the world of in both those fields, but they're not trained to respond to all medical emergencies. Right? And the expectation is who is under the roof is able to respond. You cannot do a rural health care visit in the hospital, or to a hospitalized inpatient, or to a outpatient, to a hospitals or critical access inpatient. But if that patient is under the roof of the hospital but classified as a swing bed, you could see them. But remember, documentation is going to kill you, make you, or break you. Make sure it's documented. This is a swing bed. No rural health care visits in a hospice unless it's for a non-hospice reason. Now, hospice has expanded dramatically in the past couple of years, so it's quite possible you could see them for something other than the reason for which they got classified as hospice. And again, the bills it gets confusing because it could be a mixture of covered and non-covered on the same bill. Medicare is okay with this. In fact, they made a point of saying if you have a bunch of non-covered charges, go ahead and bill them, because then they can send you the denial and then you can pursue through the other insurers. In fact, that works the opposite too. If you have another insurer that's the primary and you need to get their denial before you can submit it to Medicare as a secondary, go ahead and submit it, get it done and get it over with. But the training that Medicare puts out and the notices that Medicare puts out does say to label them as non-covered, and there's a code for that. In fact, on the one of the handouts you get is from a publication from Medicare called the Medicare Learning Matters. If you don't already subscribe to these and get on their mailing list, you probably should. It's a newsletter format that Medicare puts out, and it's for whatever topic that they've seen a lot of issues with. So it's really kind of it's kind of an advance warning. If they see it necessary to publish a Medicare Learning Matters on it, that is something you probably ought to read real carefully and make sure that you're complying with those particular rules, because they saw enough need to publish it. It means they're going to start watching for it. All right, telehealth versus virtual health. Again, virtual health is new. It's not the same as telehealth. Virtual health is more of just the technology-based communication. It's not necessarily diagnostics. It's not necessarily where there's evaluation of somebody's actual physical condition. It's a communication. It does have some limitations for payment. It has to be not related to whatever you saw them for within the past 7 days, and it cannot lead to a visit in the next 24 hours. If it leads to a visit, if you're talking to them on the phone and you say, I need to see you tomorrow, then you're going to be billing a rural health visit for tomorrow, and the communication time is considered part of the rural health care visit bill. There's your codes you need to use. I will tell you watch those because I suspect they're going to be refined after this year. This is the first year they can be used. They're going to watch how many people are billing and how many times, and I think that we'll see changes in those. Currently, the payment gets set annually, and currently it's $13.69 for a properly documented virtual communication. Now, that may seem like nothing, but if you have a 10-minute conversation and it's to check on a patient's, how's your blood sugar doing at home with your blood glucose machine, and you're documenting this, that's well worth the money, and it goes a long way to keeping your patient healthy and adherent to their treatment protocol. So here's the differences between telehealth and virtual health. They view telehealth as being more complex, more skill needed, more medical decision-making needed, so they're paying it at a higher rate. It has to be an interactive audio, okay? Interactive, that means live. That means somebody going back and forth, able to ask a question of you live as a provider. Where virtual communication could, they don't like it, but it could be what they call store and forward. It's kind of where you could leave a voicemail if you can do it in a properly HIPAA-compliant way. But it's just a very brief thing, and it can be one way at that point in time. Patient portals is a perfect example where you leave a reminder message, please call me if any of your blood pressures are above 140, something like that. Either way, they're nice touch points with your patient, and I guess my opinion about this has changed over the years. I think the more we can do with the patient in their native element, if you want to call that, sitting at home. I practiced in very rural areas up in West Virginia, and the bingo halls up there were the areas where you caught people. I guess that's where they went every Tuesday night. So we did a lot of clinical care in a bingo hall. All right. The key on telehealth, now this is not virtual health where it could be one way, telehealth is two-way, is there's what they call the originating site. That's where the patient is located, and then the distant site is where the provider is located. It gets confusing because some people will have a provider on both sites. They'll have like the nurse practitioner at the originating site with the patient holding the ultrasound probe or something, and then the physicians at the distant site doing the interpretation. But remember that you can only bill if you're an originating site. You can't bill as a distant site. Now, your provider can bill for their time at the distant site, but you can't bill a facility charge because you're not using your facility. All right. Transitional care and chronic care. All right, this is the fun one, I think. This actually has a lot of potential for income for rural healthcare centers, but you got to be careful of the rules. Chronic care management has been, 3 years now? Maybe 2 years, maybe 3 years now. They've been paying for chronic care management. Now transitional care management is popping up. This is that post-discharge coordination of care. But it involves a provider, not just case manager, right? It involves the provider, that your family practice guy who wants to, who will start looking at what happened when you were at the hospital with the hospitalist. And now you're back home, and what do we need to do? What do we need to look at? Let's look at your meds. When do I need you back? All that coordination of care. The trick with this is that some surgeries have what they call a coding global period. That means that everything within a certain period of time prior and after to the surgery is considered a one-price-fits-all, right? Most abdominal surgeries, most cardiac surgeries have a global period, and ranges in time period from 10 days to 30 days. So if you're the family practice person seeing that patient within that 30 days, you cannot bill your transitional care management. If you are let me back up. If you're the surgeon seeing them after the surgery, you can't bill transitional care if it's within your own global period. If you're the family practice guy, you didn't do the surgery, you're following up with them, you can bill a transitional care management. So there's some opportunities there. Remember that on your cost report, you're going to list these various codes that I've got all categorized out. Remember that it's called, there will be HCPCS codes. They're all the G codes, and you'll be billing those depending on which one you're going to use under which category. Incident 2. Incident 2 continues to be an issue. I'm not sure why, because they've been very clear about their rules for some time. I think it's just too much of a temptation. The difference of Incident 2 is when somebody else provides a service subsequent to a physician's initial service and treatment plan. I need to emphasize the treatment plan has to be part of that initial service. The physician has to actually list out everything they want done on the subsequent visit. The trick with this is if it's classified as an Incident 2 service, it gets paid at the physician rate. If a nurse practitioner or PA is doing it and it's not considered Incident 2, then it is not paid at the physician's rate. It's paid at the mid-level rate, which is only 85% of the physician rate. So I think there might be a temptation of money going on here. But the original intent of this was for the patient to come back in and only be seen by not an advanced level care person. The perfect example is the patient was seen in the emergency room and had sutures put in and was told to follow up 10 days later in the doctor's office to have the sutures removed. And they come in and they have the sutures removed by not the doctor who put them in. Well, that could literally be a Incident 2 service. They were told to do it. It was part of the plan. You know you're going to remove sutures in a certain number of days, and it was done as ordered. The trick was your physician has to create the treatment plan. The subsequent visit, that incident visit, has to be for the same medical problem and nothing else, nothing else. And the documentation on that subsequent visit has to very clearly state, this is a follow-up visit for blah, blah, blah after the visit on such and such a date, right? And then the one that gets them is the physician has to be in that office when that Incident 2 service is provided by whoever provides it. And I will tell you, this is where they get them, right? Because why would the physician say have somebody else see it if they're going to be in the office anyway? So it gets into a situation, sometimes the physician wants to maximize his or her time, and they'll say, I'll see these patients that require some medical diagnostic thinking, and then I'll put the patients who don't over to my NP or PA. That's an okay way to do it, but you got to be able to make sure your documentation is clear at that time. The physician cannot be rounding on hot patients in the hospital when the NP is at the clinic and still be billing incident to. At that point, if the physician's not under the roof, that visit is billed under the NP or the PA's number. So here's a nice description of it, and this is something, this kind of side-by-side comparison is how I try to train my providers, because, again, they're not looking at it from the payer point of view, they're looking at it from the clinician point of view. All right, so I don't think this is one of the handouts you got, or you would have got them later. So this may or may not work. Cassidy, did this go out prior to this survey, or will this prior to this presentation, or after?
It will go out after.
Oh, okay. So this won't work then, guys. This was one of those online polls where it shows how many people visit. But let me give you the scenario, and let's see if I can pull it up here. Nope, sorry, it's not going to work. This is a scenario where I was basically trying to get you folks to answer. It's a situation where a patient was seen first time, new patient, seen first time for new onset diabetes. The physician did a thorough treatment plan with the patient, did labs, trained them in their disease management and how to test their blood sugar, gave them a prescription for their oral anti-glycemic, and they were told to come back in 1 week and have their blood sugar tested by the staff at the facility. So when they came back, the staff at the facility saw them, tested the blood sugar, told them how to adjust their oral anti-glycemic, the diabetes medicine, and refilled their hypertensive medication. So the question came, could you bill this as an incident to visit? And the answer really is no, because they addressed an additional patient condition of hypertension, which was not on the treatment plan in the March visit. So therefore, it has to be billed under the nurse practitioner's number. The other thing was the physician had told the patient to come in a week to have the blood sugar checked because they were going to be on vacation or something. I forget how I worded it. And that would not be an incident to visit at that point anyway. There it is. All right, so we're going to talk a little bit about E&M in our last couple of minutes. We don't have a whole lot of time. The E&M is Evaluation and Management Codes. Those are the codes that are used for professional services, not facility services. This is for when you are the person that's actually billing for your doctor, your nurse practitioner, or your PA. The hardest thing that coders have to deal with is that they are not allowed to code based on a guess. And I will tell you, when I quiz people all the time, I'll quiz my physicians and I'll say, what code can your coder assign to a patient that you documented had a fever, blood in the urine, and left flank pain? And the physicians are all like, yeah, that's a urinary tract infection of some sort. Well, I'm sorry, a coder cannot diagnose. They're not licensed in any state to diagnose, so the best they can do is code the symptom only. And that's a hard concept for a clinician to understand because they are, I mean, it's painfully obvious to them, okay? So they're used to just, being able to follow through without actually documenting. And it does have to be documented. The other thing is coders now, very rightfully, will sometimes go question the doctor and say, hey, I don't have enough information to code a diagnosis here. All I've got is symptoms. They are not allowed to say to the doctor, if you put such and such down, I can then code it such and such. Right? Because that is actually considered leading the provider, and it's considered fraudulent upcoding. So it becomes this interesting little conversation between providers and coders. The coders are not allowed to tell you what to write, and the providers, because they're not coders, don't know what to write. So the best advice I can give you is there are a lot of clinical documentation improvement forms that you can institute at your organization that have keyed phrases to make the providers think, what else do I need to document? The other thing is they're not allowed to document or rule out diagnosis. So which makes it interesting because most admissions are kind of very fuzzy on their diagnosis, very cloudy on initial admission. But by discharge, you should have a firm diagnosis. And that's what the coder will have to code preferentially to the discharge diagnosis, not the admission diagnosis. All right, so the fun comes is the E&M is changing. There have been some changes for this year, 2019, where they're kind of they're backing off on all the documentation requirements for some of the things that were just duplicative. You don't need to redocument at every visit if you did something on a prior visit. So the typical example is somebody that had to rewrite a patient's entire past medical history. And up until January of this year, you were not allowed to say see previous history. You had to actually, if you said see previous history, you would have to give definitions of what else was in that previous history, which is basically rewriting it again. Now they're letting you say see previous history, I have reviewed and no changes are necessary, sort of like when you do a consent form. The other thing is the chief complaint now no longer has to be written by the provider. What used to happen is everyone had their front office nurse or their back office nurse write the chief complaint, and the physician would have to rewrite it, which was just plain silly. So now they're saying, all right, you can have your support staff write that, because all it is, a chief complaint is the patient's words, not any kind of medical decision making. So now the ancillary staff writes it, and the provider will say reviewed. In 2021, if you look in that lower left-hand corner, the big changes are going to happen. So not this year, not next year, but the year afterwards. They're going to change the payment schedule. So instead of having 5 levels of payment, there will be 1 level of payment. It will be a payment at the level 2, which is really a very simple office visit, hardly any decision-making needed. And your documentation only has to be at the level 2 visit. So immediately your workload is lessened. Unfortunately, when they put that out, there was an uproar from anyone who deals with any kind of chronic disease management, because if you have any kind of patients who are diabetic or congestive heart failure or even hypertension, you rarely have a very simple visit. There's always lots of things you have to look at and balance, and the medical decision-making is fairly complex. So there was an uproar from those people, and so they created a new code called an extended visit code. Now, we've always had extended visits of some sort, but these they're going to pay for. They have not put out what's going to have to be documented in those extended visit codes yet. So what's going to happen is you're going to see a lot of people coding at the level 2 visit, whether it's new patient or established, and then they're going to have an add-on extended visit code. How that all works out has not yet been published. So remember, under E&M coding, you really have 3 portions. There's always a history, some level of history, some level of exam, and some level of medical decision-making. Unfortunately, and I count myself in this group, you get to a point where you sort of guess after a while. Well, I know I'm going to spend this amount of time on Mrs. Jones because I know what's going on with her. And unfortunately, the documentation doesn't often reflect that same level. You'll see in your handouts, there are basically charts, right? One for history, one for exam, and one for medical decision-making. What I did for my clients, I just put it all on a cheat sheet, and I did provide you one version of that cheat sheet. It'll be in your handouts that you get, and it's set up, I set that up basically on a family practice type of practice. If you are a specialty clinic like ortho or neuro or something like that, or if you have a lot of dental patients, something that requires a little more difference, you may want to look at your cheat sheet and see if you need to tweak it a little. But basically just put these cheat sheets on your clipboards or in your rooms or next to the computer so that it can be a visual reminder to the provider that they've only documented, let's see, under a history of present illness, if they've only documented 3 points of information, the best they're going to be able to do is a problem-focused or expanded problem-focused history. So, and each one, history, exam, and medical decision-making all have their own levels, and then you match up the levels from each one of those components. How this matches up is either based on the 95 or the 97 guidelines. You are allowed to use whichever ones you want until 2021 when everything changes. Most people end up using the 95 because the 95 just counts how many bullet points you have. On the 97, it starts counting how many organ systems did you look at and how many bullet points within each organ system. It gets a little more complex. The only thing you're not allowed to do is mix systems within the same practice. You are either going to choose to use 95 or 97. So just like history had those levels, exam have levels. Here's the elements that you have to do. You can see it's like 1 to 5 bullet points, 6 to 10. Think about this. If you're examining somebody, and those of you who do billing probably have looked at the clinical documentation, you're not just looking at one thing. You're always looking, what is their general appearance? How are they communicating with you? Is their language, is their communication slurred? Are their eyes focused? Are they able to walk into the room? So there's multiple body systems they're looking at. You could easily get to the 6+ bullet points and get into an expanded problem-focused exam. Medical decision-making is the one that is interesting because Medicare has not made definitions of what minimal, limited, multiple, and extensive are. They are, it's left up to interpretation, and that sometimes gets muddy during the challenge or the audit phase. Most of the time, if you do not document that you have to, this might happen, or I have to consider this because this might be a complication, or I have to look at that, or I have to go back and look at past medical records. If you don't document that stuff, the best that Medicare will let you call it is a minimal or a limited level of complexity. So do please document those things because everybody looks at previous medical records. Everyone thinks about what could be the possible complication. Just document that you did that, and then you get to take credit for a slightly higher level of medical decision-making. Here's the one that is the most important. When you think about it, under history, under exam, and under medical decision-making, you're going to find your level under each one of those previous charts. Did I have 1 to 3 bullet points under my exam? Well, then the best I'm going to get is a problem-focused exam. Did I only speak about the plan for the patient's current medical problems, and I didn't talk about any of their chronic care? I didn't talk about any complications. I didn't talk about any societal determinants of health. Then the best I'm going to have is a straightforward level of medical decision-making. So the way that Medicare looks at this is they expect you to define what level of history, what level of history, what level of exam, and then what level of medical decision-making, and line them up on a horizontal line. Okay, time is not a factor in decisioning the level, right? You can put, if you had extra time, and then you can add a modifier or you can add an additional add-on code, but it is not definitive in deciding what level of care. So let's say you had a detailed level of history. Maybe you had somebody help you take a lot of the information prior to the patient getting into the exam room. You only had an expanded problem-focused exam and only a straightforward medical decision-making. Well, on a new patient, you have to level it at whatever level had all 3 items. So if you had detailed here and problem-focused, expanded problem-focused, and straightforward here, the best you could claim was a 99202. Now think about new patients. You do a lot on a new patient. But the best your biller, your coder is going to be able to do, if you don't document it, is to get into that expanded problem-focused and straightforward. That's a lot of money that's been left on the table that way. There is a quiz here, and I think this will probably be the last thing we can do here. If you're coding from the provider's documentation, this is a new 78-year-old patient, all right? Chief complaint, this is what she says. I think I have ovarian cancer. Now look at the bullet points here under present illness. 2 weeks, left flank pain. That's actually 2. That's a duration and a location. Pain on urination, that is 3. Feels like she has to urinate but can't, 4. Not sexually active for years, 5. No change of bowel habits, 6. Had 6 points in that present illness. Think how easy that was to document, because you're going to ask those questions. Now, but under review of systems, which is part of the exam, or part of the history rather, pale and clammy, limited ability to turn from side to side. That's only 2 bullet points. You're really kind of losing your momentum by not documenting a lot. And then you had some family medical history, 2 little bullet points. The best way I can tell you to work around this is if you're under an EMR, make sure your EMR has a lot of checkboxes, and that your providers, the clinical people, are looking at what the checkboxes have, because they're the ones that are going to be able to check more or less boxes. So under the exam, think of the number of bullet points you could do. You've got bowel sounds, that's 1. Vaginal exam, that's 2. Breast exam is 3. That's really only 3 bullet points. That's a very limited kind of exam. But if they truly are thinking they have ovarian cancer, the doc's going to do more. The doc's going to be looking at the skin, looking at general body habitus. They're going to look at other things. Make sure they document these. And the medical decision making, how many lab tests are they looking? What kinds of things am I thinking I need to check? What do I need to look for? I'm sorry, I don't know what that will is in there. That was not, do they have a will? That it was something about what they were willing to schedule. So you've got 5 points there easily. And I apologize, the poll was not going to work for us. All right, so what this turned out to be is, because it was a very detailed history, but only an expanded problem-focused exam, and it was a new patient, so that means your 99213 couldn't work because that's an established patient. So it's either 99202 or 99204. So the difference between the two is whether it's a straightforward medical decision-making or a moderate decision-making. And unfortunately, that was only a very straightforward medical decision-making. There was no description of what other concerns we have, what kind of complications. All right, to close, on next steps, no one's going to be perfect. There's always going to be a chance to get better. So the clinicians need to spend time with the business side. They need to find out how bills are, how does the bill get created? What do they look at in the chart? How fast can they get the chart? Is it sitting on my desk while I'm waiting to document? Ask them about how often they get something denied. How effective is my billing process? How many denials do I get, first denials do I get that I have to rework and send out? Spend time with the staff, both on the management side and the billing side. Do they have everything they need to do their job? And I'll give you a perfect example. One of my clients had a back office nurse who, for whatever reason, was the one assigning the ICD-10 code. Well, she had to walk up to the front desk to get the ICD-10 manual every day at the end of the day, and then do all her coding assignments. Just think how much more effective she was once we got her own ICD-10 manual for the back office. It could be very simple thing. And this one right here, the second bullet point, you check your OIG's list of excluded individuals. That is not a one-time only thing just when you hire them. That's the list of people who, where Medicare refuses them involvement in any Medicare activities, and it's called the List of Excluded Individual. It's free. You can just go Google it. It's OIG's website. But things happen over time. So you should be checking on your employees every once in a while. It doesn't necessarily have to be every year, but you need to repetitively check them over the course of their employment, because stuff happens. There have been lots of times when somebody with an absolutely clean record, when you hired them, they've been with you 32 years, but they went through a divorce maybe, and things got rough for them, and they were a little too tempted by the money in the drawer, and they got caught and by one employer, and they got put on the list of excluded individuals by CMS. But then you hired them, but didn't bother checking them, and now you've got somebody working for you. If you have hired somebody on the list of excluded individuals, you can have all your reimbursement cut. So it is something to watch. There's some ideas for audits that you can try. If you're on the coding and billing side, you may not be thinking about how do I check to make sure everything's working the way it should be. So here's the topics we talked about today: the facility billing at the inpatient, the rural health, medical necessity hot buttons, and E&M. And the next couple of slides here are all those references that I've been referring to. Please do check them out. You've got a lot of good information. Be aware that there's a lot of people out there that have good tools, nice little cheat sheets, everything. Don't be afraid to borrow, respectfully borrow. And again, a lot of things like your E&M coding manuals and your ICD coding manuals are available free on the internet. So I think I've really taken up a lot of time, and I will tell you, if we don't get your questions answered, Cassie, just email them to me, and I'll send your emails back, and you can distribute them that way.
Hey, that sounds great. Thanks, Patty. That was excellent. We have 2 questions. Would you like those, or would you like me to have them emailed to you?
And let's go email them, and then we'll that way everyone can get to them.
Okay, well, we thank you so much. That was really wonderful. We really appreciate it. And I just wanted to let everyone on the call know that we will be sending the slides out as well as all of the handouts and a quick survey. This survey takes less than a minute, so please, if you will, take the time to just let us know what you thought of the presentation and give us any feedback on future topics. All right, thanks, everyone. And the questions that are in the queue will be sent to Ms. Hildebrand, and we will get back to you. Thanks so much for attending. Bye-bye.
Thanks, folks.